All right. So hello, everybody. Thank you for joining me. Really happy to be here. As Jen said, I presented a similar presentation at the San Diego Pain Summit, and this is a topic that is just I'm so passionate about. And as Jen said, I'm a physiotherapist, I'm a yoga therapist, and I've been integrating yoga into my physiotherapy practice for over 20 years. And I started back in 1998 when my story is sort of that I started the yoga first, and then when I got my physiotherapy degree, I started to integrate yoga into my practice. And so from really the beginning, I started to see how I can integrate all of these different practices and philosophy, one of which is compassion. I just didn't really have the language for it back then. But that's sort of what had led me throughout my career, and I worked in a lot of different settings. One definitely being working with people with persistent pain. And just fast forwarding, I met Neil Pearson, who many of you know listening to this, and he's been a huge part of Pain BC, and he has webinars and all kinds of different resources on here. And so I met Neil over a decade ago and started just to work with him and learn from him. I'm also a pain care yoga trainer, and that kind of gives you a background, a little bit of a background. And the compassion piece, I'm not going to go into that story, but it's, just over the years, like I said, through yoga. Yoga is inherently a compassionate practice, and compassion emerges from yoga. And then as time went on, myself and Neil Pearson and Marlisa Sullivan, who's another physiotherapist and yoga therapist, we co-edited and co-authored a textbook, Yoga and Science in Pain Care, Treating the Person in Pain. So with that, I wrote a chapter, Compassion in Pain Care. And over the years, writing that chapter and researching all that I needed to write the chapter really was a huge, facilitator that brings me here today. Okay, so let's just dive in. So I guess I should talk a little bit about my conflicts of interest. So I am a sole proprietor as a physiotherapist and a yoga therapist. So I have a small clinical practice here in Sylvan Lake, Alberta, Canada, and I'm also a continuing education provider. So I do receive income from the services and products that I provide for both healthcare professionals and people in pain. And I will be talking about a product, and so I just want to disclose that, and I will be very explicit when I do talk about it and not be sneaky and give you any kind of subliminal messages. So I'll be very clear when I am telling you about one of my products. And then I wanted to add this as one of my biases, which is that I believe there is tremendous value in integrating compassion in pain care. So that might be obvious because most of us do talk about things that we believe in, but I do look at my work as very evidence informed. So I think it's important that you all know, while I am going to be sharing evidence around this, and I am, in my book chapter, I do take a critical review of the literature. And in this presentation, I'm not going to go deep into critically reviewing the literature. I will mention some, and I will also mention the gaps that we have in knowledge and the limitations in the research. But I thought it was important just to let you know that personally, I do believe that there is a place for compassion training and this talk of compassion in pain care. So what we're going to go through in 45 minutes, we're going to describe and define compassion, look at the benefits and some of the challenges that we face in providing compassionate care, and then if and how we should train compassion. And I'll just briefly go through the difference between empathy and compassion, not get into the weeds into it too much, but just briefly look at that. And then this idea of compassion fatigue versus empathic distress, and then an overall model of compassionate pain care. So when we look at compassion, often when I talk to colleagues and other healthcare providers, at first glance, it almost seems like it should just be very natural. And do we really need a whole webinar talking about this? Do we really need to, be training for it and discussing it? Because we are healthcare providers, and it really should just be part of what we do. And some people think, well, it should be quite simple. Just don't be mean. Just be kind, be nice. But it turns out that it's a little more complicated than that. And I really want to show you the nuances of compassion in this presentation. And again, some of the challenges that we do face in providing compassionate care. So what is it? There's actually no one agreed upon definition, but the Oxford Handbook of Compassion Science does have a working definition. And they have the two components here. And they say the working definition in that textbook, which is comprised of all the leading compassion researchers around the world. And they say it has two components. So the first, we have to be able to recognize that someone's suffering or struggling, and then have the motivation to alleviate it. And Paul Gilbert, who's a professor and also one of our leading researchers of compassion, talks about these three orientations of compassion. So the first orientation is giving or offering compassion, providing a compassionate response. The second one is receiving. So you have to have that capacity to actually receive the compassion that's being given to you. And then self-compassion. And self-compassion, you can look at the definition of recognizing the suffering or the struggle with the motivation to alleviate it. And you can apply that to yourself. So giving and receiving compassion towards yourself. And I just like this quote from Jack Kornfield: if your compassion does not include yourself, it is incomplete. So as we go through this talk, I do separate it into self-compassion and compassion for others. But it's not really the way it works. Compassion in and of itself is always including yourself. But it's just for ease of explaining, it's just easier to kind of separate it. But just keep that in mind, even when I'm talking about compassion for others, there's still that element of yourself within that. And I'll talk more about that later to be more clear. So Kristen Neff, many of you may have heard of her. So she is a psychologist, a professor of psychology at the University of Texas at Austin. And she is one of our leaders around self-compassion. And she's been studying this now for almost a couple decades, or at least the work has been published it started to be published in the early 2000s. And so she has developed even a self-compassion scale, and she looks at self-compassion as these three elements or components. So the first component is mindfulness. And that's just very simply being aware and fully present to your moment of struggle or suffering or pain. So basically, looking at this, sometimes people think, well, of course I know that I'm struggling. And if you dig a little bit deeper, sometimes we don't actually acknowledge it. Sometimes we are maybe caught up in the story or the emotions, and we don't take a moment just to be fully mindful and present and just say, I'm in a tough moment here. And whether it's you're feeling bad because you made a mistake, or maybe you said something you didn't want to say, or you didn't say something that you should have said, or maybe someone has hurt you and you become kind of hard on yourself for whatever feelings come up with that. Maybe towards someone else you have ill wishes or feelings. So regardless what the situation is, it's just this idea that you acknowledge and say, okay, I'm really struggling right now. And then the second component is common humanity. So Dr. Neff talks about this idea that you're not alone. You may feel like you're isolated, and that really this is you're the only one that this may have happened to, or that, if we have that self-critical talk, like, oh, how could I say that? How could I do that? And we get really hard on ourselves. And we just think that nobody else would do what we did or said what we did. So it's this idea that, no, you're not alone. we're in this together. Many other people have these experiences, and many other people right now in this moment are having a similar experience. And then the third component is kindness. And this is the idea that you take now a moment to extend some sort of support towards yourself. And that is a whole other topic. Of course, in my work, I go through this quite a bit, but all the different ways that this might look like. How do you extend kindness to yourself? It could be just something you say. It could be a little hand gesture. It could be just a moment of stillness. It might be removing yourself from the situation and just having a quiet moment. All kinds of different ways, and some even little meditations and things that maybe work for you. So those are the three components. And I want to just stay on this orientation of self-compassion for a moment and look at what some of the research is telling us, and some of the lived experience of people in pain have been telling us about self-compassion. So I want to take this first little bit and tell you about something that Joletta Belton writes about. And Joletta, as many of you may know, had a webinar as well here on Pain BC, and I strongly recommend checking that out. And she actually writes the first chapter in our textbook, The Lived Experience of Pain. And so I just want to take a moment to tell you something that she talks and writes about, which is extending kindness to oneself can be difficult for people in pain. At a time when feelings of shame, guilt, anger, grief, sadness, despair, purposelessness, hopelessness, and worthlessness might be prevalent. We may not like ourselves anymore, and we perhaps may not like who we've become very much. And this is not only from Joletta, but listening to stories from many other and many others that have pain in my own clinical practice as well. And the years that I've worked with people in pain have a similar story. And we even know from the research that people, when pain persists, can start to feel these feelings of guilt or shame. And it may be because we feel bad because we're not making these healthy choices, or we're not responding to the treatments, or we're lacking focus or concentration. We can't remember the information that's given to us. Maybe we can't follow through with the home exercises. And there's all these different things, and even maybe we're not fulfilling our responsibilities around the house or at work. I mean, there's just so much that goes along with that. And then we have maybe these feelings of guilt, shame, or anger. And so, I think when we look at self-compassion, and what I've seen with the literature is that it can help mitigate some of these things, which is fascinating. So I want to read one more quote from Joletta, because it's so beautiful and so profound. So she says, and this is taken from the chapter, "I was quite angry and upset with myself for a long time, beating myself up constantly for not being able to figure it out, for not doing this pain thing right, for not getting better when I was supposed to. I beat myself for being in pain at all, for not handling it better, handling it like I should have. It took a long time and a lot of practice to begin to be kind and compassionate with myself, to see that I'm just human, just trying to figure it all out like everybody else is, having very human experiences, of which pain and suffering were a part. I'm more kind and compassionate with myself now." So thank you, Joletta, for sharing that with us. So this slide just shows you some of what the research is telling us. And I just compiled, all the research, and later there's resources in the book chapter. You have all the citations. But basically, this is what the research shows, that people that have higher levels of self-compassion show these associated with these things that you see on the screen. So reduced anxiety, depression, and so forth. You can read through those. Now this, just to be clear, is in the general population. So this is not specific to people in pain per se. But I wanted to highlight a couple things on here. So one is the self-criticism and the reduced self-criticism, and then the increased motivation and health promotion behaviors. And I think that's really interesting. And some of what Kristen writes about is when you look at the literature on self-criticism. So, you know, when we sometimes think that being self-critical or being a little bit harder on ourselves will motivate us more to change our behavior. Well, what the research shows is that that might be true for some of us short term. And you can even maybe take a moment and think of an example for yourself, you know, when you think, well, that works if I can just, you know, say, come on, and be really hard and with a sort of a harsh tone of voice, it makes me change my behavior. So, you know, I have to do that, not be kind to myself, because that will make me just sit back and not do anything. What the research shows is that even though with self-criticism, the behavior might change short term, it's not sustainable, and it's more related to higher feelings of anxiety. And that motivation to change is rooted in fear that you're not enough, even fear you're being in competition, whether it's with culture, society, others, or even just being in competition with yourself. Whereas the research in self-compassion shows if we have that response of being kind to ourselves, we're actually more likely to change our behavior. We're more motivated to try again after making a mistake. We're more likely to try new things. And the behavior changes are more sustainable. And it seems that the motivation to change, when it's rooted in this self-compassion, that comes from a place more of love and real genuine concern to care for yourself, to alleviate your struggle, the genuine care to really support yourself. And, you know, when you take some time to learn more about self-compassion and some of the practices and what it looks like, well, for my own personal practice and then for the patients that I've worked with, you know, there's a consensus that, you know, this does make sense. So I encourage you, if you're interested in this, to maybe start to dive into it and see for yourself. So that's the literature here for just in the general population. Now we do have, from what I can find, we have about 6 studies out there. There may be more. So if anyone does see any more, please send them my way. But 4 of the studies are studying self-compassion as a trait. So you're not manipulating self-compassion, but just the level of self-compassion in people in pain, with persistent pain. And this first study here, this is what it shows. So people in pain, so this was a self-compassion in patients with persistent musculoskeletal pain, relationship to self-compassion to adjustment to persistent pain. So people with higher levels of self-compassion showed this: reduced pain catastrophization, reduced levels of disability and negative affect, and improved pain self-efficacy and positive affect. And I'm just going to briefly go through the other 3, not in detail, but this just to show you, this was another study that showed these things. So again, higher levels of self-compassion showed this. And the third one, higher levels of self-compassion showed these things, which now we see on the screen: increase pain acceptance. And then this last one, which was from this year, Edwards and her group, the relation of self-compassion to functioning among adults with chronic pain. And you can see here, this is what it was associated with. And that includes more successful with their pain coping strategies and activities that they valued. And then the last 2 studies, now these last 2 are actually the effects of compassion intervention, so compassion meditations. This first one was a pilot study, and you can see there the title, Pilot Study of a Compassion Meditation Intervention in Chronic Pain. And I think it's important here to point out that this was, they had a, let me just think of this was the one, there was no active control. So the intervention group served as their own control. And there are limitations because we're not sure, you know, is it the specific effects of the compassion meditation, or there may be some other things involved, like being part of a group and some of the group discussions and things that they've had. And then this last one here, same idea, you know, some of the limitations with this one. So this one, by the way, was a loving kindness meditation for people with chronic low back pain. This was a randomized control trial, and they compared this loving kindness meditation with usual care. So limitation here is they don't describe what usual care is. So I'm not sure what that was. And then the same limitations here is that we don't know any specific effects because they did other things like body scans and again, group discussions and things like that. So that just real brief, but kind of gives you an idea there. And I think I will just, disclose here and just say that more research is needed, obviously, to show that self-compassion training is indeed appropriate and effective for people in pain as an intervention. And we don't know if there's any adverse side effects. I'm kind of biased or very biased, and I'm not sure that there could be, but there might. I mean, you never know. And what we do see, though, is that this compassion does seem to allow people in pain to respond to their challenges with more kindness, more compassion, instead of that shame and blame and anger. And that might lead to potentially healthier behaviors and improved stress management and resiliency and things like that. So just looking here now at self-compassion in the healthcare provider. So for those of you listening who are healthcare providers, we have some evidence that actually shows that this helps us as well. So I'm not going to go as much detail into this, but again, I just compiled some of the research, and here's what it says is that increased self-compassion can help with the increased physical and psychological health outcomes, emotional resiliency, and concern for others, which I think is interesting. We have research that shows increasing self-compassion can translate potentially to help us be more caring and have more concern for others, but not the other way around. So training in compassion for others doesn't yet translate to increased self-compassion. I think that's sort of interesting. And then, of course, we have some preliminary research showing that self-compassion may potentially help to mitigate against burnout and empathic distress fatigue, which I'll get to later. So now looking at this orientation of compassion for people in pain. This might seem a little bit obvious, what the literature says here. The more compassionate care we can give people, the better quality of care results, increase patient outcomes and satisfaction, and improve therapeutic alliance, and can even lead to increased self-care on behalf of the person in pain. And I want to highlight this because I just think this is an important message for all of us. So there was this study done. It was 1 year long in an integrative rehab hospital in Sweden. And what they found, basically the aim, it was 10 women that were living with persistent pain, and they were really trying to explore the patient's self-care experience, and they wanted to track their progress in self-care. And so what they found was that the women were only able to take successful steps toward active self-care once they were able to experience loving and compassionate care from the healthcare provider. And the women it was a qualitative study, and the women reported things like they felt well cared for, respected, listened to, worthy, whole, and even loved. So I think that's important to point out that, we know how important self-care is, self-management in pain care. And as healthcare providers, we're doing our best to help people that we're working with to, what can you do to take an active role here? And this is one piece of information that I think is really interesting, that, the compassion, for them to experience compassion may be an important thing to come first. So the study they quote here, this comes straight from the paper, and they say self-care has to be much more than advice, education, and training for people with complex suffering. The journey to health begins when the sufferer experiences what it is to be cared for. And this orientation of providing compassionate care to someone else, to the patient, to the person in pain, can also, the research shows, also can help the giver, the caregiver, the healthcare professional, can potentially help protect against burnout and decrease anxiety, depression, and even reduce medical costs, errors, and malpractice claims. And of course, just overall improving overall health and well-being. Okay, so moving on, kind of taking a turn here to this idea that we know that compassionate care is important. And I think we all probably knew that before I started this webinar. So we know it's good. We have the research to tell us that it's good. But why is it that sometimes we don't maybe always offer compassionate care? And this is, of course, we're talking in the context of pain care, but you can extrapolate this even to your own personal life and think of times when maybe you're not as compassionate as you would have liked to been. And then we use that self-compassion and to understand behind the reasonings behind that. And it's not excuses, but it helps us understand and give us some information. So these are fears, blocks, and resistances that Paul Gilbert talks about. And I'm gonna go through these briefly, but they're obviously, I talk about them in more depth in the book and in my training. So one reason why we might not be as compassionate as we think, as we would like to be rather, is our own distress is high. So if we have unmanaged personal distress, our physiological state is in a state of, we could say dysregulation, maybe it's autonomic nervous system dysregulation, fear, fright, flight, but overall just think if we're in this state of distress, neurobiologically, we're not wired to give because we're not feeling safe. We don't have those resources. So that's one way to look at it. We may be overwhelmed by the person in pain and their story. And if we don't have the resources, again, to regulate and to be able to take things in stride, to have therapeutic humility, which I'll talk about, not being attached to being the almighty savior, the person that has to fix everything. So there's a lot that goes with this, this point, but basically just keeping in mind that the research shows when things are more digestible and palatable, we're more likely to be compassionate. And when they get a little more challenging and complex, it's harder. And that makes sense. And we may have the belief that compassion is unhelpful. So this goes back to that idea that if, we were raised in such a way, if we have a deep-seated belief that, that compassion is a soft skill, or that, the person really needs, a harder sort of approach, something a little more stern, that compassion is something that will just, sort of make us or make the person not be able to change the behavior or make the changes. And it's well-intentioned. It's just that if that's our deep-seated belief, then that might interfere with a truly genuine compassion response. And then we have the fear of the cost of caring. So this is really the idea that we just are afraid maybe of things like our own health. In some cases, it's that we are in danger. I don't know if that would relate to the therapeutic interaction per se, but maybe a fear of this idea of compassion fatigue, or we have to really protect ourselves. And then there might be organizational barriers. So please keep in mind that this isn't all, on the healthcare provider and your state and your life. And, there may be barriers, paperwork, productivity standards, just the way the culture is set up, shortage of time with people. So this may be a block that may prevent you from providing compassionate care. And then social pressures as well. So if your environment in the workplace is such that compassion is this idea that it's a soft skill, it's not welcomed, that might be a factor as well. So then we look at this idea of, is compassion trainable? And so if we know that there's some of these blocks and these fears and these resistances, and we know that compassion is a good thing and has all those benefits, then maybe we should train it. And I don't know the answer, but what we do know is that, yes, the literature shows us that we can actually train to be more compassionate or to offer more compassionate responses, and self-compassion as well. So there's a couple different bodies of literature again, those orientations. And the last 15 minutes here, I'd like to spend some time on one of the models of training compassion. And it is geared towards healthcare providers, but again, it can be really used by any of us in general. We just want to have a more compassionate response to emerge. And this is from Joan Halifax. So Joan is, she's an anthropologist, she's an ecologist, she's a Zen Buddhist teacher, and she actually has a program that is exclusively for healthcare providers to help foster compassion and mitigate burnout and fatigue and empathic distress. So Joan has a little bit of a different view on compassion. So she says we can't directly train compassion, but we prime ourselves for compassion by training components of compassion. And the current definition of the ability to recognize that someone's struggling or suffering with the motivation to alleviate it, she says that's a little bit limiting, because compassion is actually an emergent process that arises from an interaction between two living, changing organisms within the context of the environment. So it's a little bit more complex than just saying, oh, I recognize the person is struggling and I would like to help them. There's more of a wisdom behind it, which I'm sure you can appreciate, because there's no protocol or recipe, meaning what might be a compassionate response for one person with the same story, even a similar experience, in the context of that particular situation in that moment of time, what might be appropriate for that one person might be different for another, or might be different for that same person in a different context, in a different time, later that day or 2 weeks from now. So it's more of a wisdom, which I love this model. So I'm going to go through these 6, not in great detail, but I do want to highlight each of them. So these are the 6 components that give rise to, when primed and when practiced, give rise to a more compassionate wisdom to emerge. So the first one, attentional. So this domain is very similar to what you heard with Kristen Neff's self-compassion in the mindfulness, the first component, if you remember that. So the attentional domain is just to be fully present and fully focused within that therapeutic interaction. And that's something that we absolutely can train. You can, just by simply trying and being fully present, but also outside of the therapeutic interaction, there are things we can do. And I'm sure most of you listening to this understand different mindfulness practices and meditation can help train our brains to be more focused and attentive in the present moment. And then the second domain is the affective. And so this is the idea that the more we can train ourselves to be aware of our emotions, then the more we are able to regulate our emotions. And regulating our own emotions as the healthcare provider in this case is key to be able to provide a very clear response. And it's key to providing or to helping us have a more clear understanding of the person's story and their situation. If we get our emotions caught up in it, in our brain and the amygdala, and the idea that the emotions are just sort of leading us and we can't access this regulation, that can affect our ability to provide a compassionate response. And we have more research, which I think is really cool, that shows the more we are able to regulate our own emotions, or be aware of our own emotions, the more likely we're able to be aware of another's emotions. And that is part of this process I'm sure you can appreciate. And we can do this in many different ways. So you may be wondering, well, how do I practice this? It's sort of beyond the webinar here, but there are ways that we can do that. And some of that is through interoceptive awareness practices, potentially, and also some meditations like loving kindness meditation has been shown to speak to this point. And then we have the third domain, which is the intentional. And really what we look at here is setting an intention. And we know that when we set an actual intention, that can influence the whole process, the whole therapeutic interaction, outcomes, even our thoughts, our language, our body language, even our tone of voice, our actions. So just, that's one factor. There's many, but setting an intention can be powerful. And here's an example. This is from my colleague, Matthew Taylor. He's also a physical therapist and yoga therapist, and he's got some great resources as well. But he has this in one of his books, which I love these 3 intentions, and I also practice these as well. So just repeating to yourself before the interaction's about to take place, be present and care for myself first. It's first and foremost. Second, be present for the person in front of me. And then maybe an overarching theme or an overarching intention is, I am here to serve. I am here to serve. And just try it, even if you're interested, and see for yourself if that influences anything for you. And then the 4th domain here is insight. And this is the idea that if we cultivate those above 3 domains, it's all a process, and it can help us gain deeper insight into helping the person, gain deeper insight into the person's struggles and their story. And then we're better able to meet their needs. Again, it's this wisdom that emerges. So I hope you're appreciating how these they're not really stages, they're just domains, and they interact, and there's an interplay, they're interdependent. And I just want to say one more thing about this point on insight. And I mentioned the word briefly at the beginning, which was therapeutic humility. And Joan Halifax talks about this term that, yes, we do our best as healthcare providers, and we do everything that we can to serve. And then once we're finished and complete, we detach from the outcome. So it's not that we don't care. It's the idea that we have to have this humility, that the outcome is out of our control. We do our best, and then we see what emerges. And this kind of goes within this domain of insight, which I hope you can appreciate too, might help us with burnout. And then the last 2, we've got embodiment as the 5th, which is really this felt sense of your experience of being in your body, mind, within the environment. And there's a lot to this one as well. It's similar, I find, to the affective domain, but this one is more not just paying attention to your emotions, but just being fully present and aware in your body within the therapeutic interaction, which, if you think about it, is interesting because we want to give our whole full attention to the person and listening to their story. At the same time, though, we don't want to dissociate from what's going on within inside of us. So we're dividing our attention, which again is a skill that we can develop. And why that is important is we need to know what's going on inside of us and feel if there's some tension going on, if we're reacting. For myself, I can feel often someone is maybe sharing something with me, and you can feel a tension maybe somewhere in my throat or in my chest, and I can just check in with that, and then I can use breath to anchor and calm and just still stay paying full attention to the person, but knowing, having the skill to recognize that you're having these reactions is important in order for us to then regulate. And then the engaged domain is the final domain. And this domain, of course, is compassion in action. And, compassion is not really compassion unless you actually have an act to it and do something. So when we look at the responses from all of these domains, and then you look at the final response, what you give, if you really cultivate these domains, then hopefully we have a response that's ethical, it's value-based, mutually value-based, it's practical, and it's based on a partnership between the healthcare provider and the person in pain. And keep in mind that the response, a compassionate response, might be offering strategies or giving advice, recommending different practices, maybe helping with goal setting or daily planning. It might be active listening. It could be inquiring, asking questions. But remember that a compassionate response might also be doing nothing. It might be just providing space for the person and really just allowing the person to have the space and the time to reflect and to experience whatever it is they're experiencing. And we all know how important that is to help validate for the person. So I think, it's really important to keep in mind, again, that this is a wisdom that emerges. And I like these 3 questions as well in the engagement part. How can I best serve? What can I learn? And what does this person need to succeed? So to wrap up this model, it is an emergent process. It's a complex dynamical system, and that's where the compassion wisdom emerges. So then we say, well, is it possible to have too much compassion? So the last couple minutes here, let's talk about this, because we have this idea of compassion fatigue and burnout. So can we do this too much? Well, if you think about it, and if you're struggling with this, maybe go back and read or listen to those domains again. But if you really think about it, if you practice and cultivate those domains, it's more of a, like I said, a wisdom that emerges. So it would be, to me, like saying we have wisdom fatigue. Like it's, to me, it's not something that you can really have too much of. And it likely, when there is discrepancy of people talking, it's likely language. So from what I've seen in some discussions, essentially we agree at a base level, it's just the language that we're using. But if we look at compassion in this way, then it makes sense that it actually helps to, to foster even more. And I want to just read this quote from one of the leading researchers, and I'm sorry I didn't write the name down, but they had said, compassion seems to provide the inner resources needed to counteract caregiver fatigue. So you might be fatigued, but it's fatigue, it's just fatigue. So let's just, last bit here, go through this a little bit deeper, because I think it's important when we look at empathy versus compassion. So empathy is a whole other topic, and it's not really what I have been researching. I haven't been researching that literature as much in depth as I have the compassion. But the bit that I have looked at, it's kind of the same in that there's no one agreed upon definition. There's cognitive empathy, emotional empathy, social empathy, somatic empathy, behavioral empathy. So that makes it hard to do this if we don't have a general understanding. But let's just, for the purposes of this, let's just say empathy, what we're talking about here is that ability, that capacity to share to share feelings of another person. So this idea that, you're looking at their perspective and you can put yourself in their shoes and you're experiencing the emotions, similar emotions that they would be experiencing. Well, it turns out, in that case, what happens is if we have too much of that, the feeling that can lead, the research is showing, that can more lead to empathic distress, and not necessarily, it's not necessarily the compassion that's being fatigued. So, and I'm not going to go into details because I want to take some question and answers now, but just knowing that neurobiologically, compassion and empathy are also different, and they present differently. So enhancing compassion can counteract the potential detrimental effects of empathizing too much with the suffering of others. While empathy may lead to burnout, compassion can help foster resilience. And that's Klemecki Klemecki's work, Olga Klemecki, an empathy researcher and compassion researcher. So I think I better wrap it up because I want to take questions. So compassionate pain care, this was just sort of a review of the top two, the person in pain and the healthcare provider. This is the whole, if you look at the whole comprehensive compassionate pain care model, you see the three orientations in the beginning. So cultivating compassion for others. And then of course, if we look in the context of pain care, compassionate care for the person in pain, and then the person in pain having the capacity to receive that compassion, and then self-compassion within both the person in pain and the healthcare provider. And just knowing that this doesn't stop here. So this compassionate care, we need to involve family and friends in this, the healthcare organization, the leaders of the organization have to be in line with providing and supporting a compassionate environment. And then of course, the community at large, public awareness. I kind of rushed through that. These are some resources. This will be here. You can always scroll back and look. Some of these are free ebook. Compassion, Bridging Practice and Science is a free ebook, and some of the others there. And then our book, like I said, I've disclosed the product, which is Neil Pearson, Marlisa Sullivan, and myself, and many other chapter contributors, Yoga and Science and Pain Care. And that's where my chapter on compassion and pain care resides. And these are some other resources, which you can look at this webinar after and see what might be of interest to you. And there's a lot of free stuff on here as well. Okay, so I think I'll say thank you here and take it over. You guys take it over now and let me know if you have any questions.
Thanks, Shelly. That was extremely interesting. So we just have a question. It came in sort of early in the webinar. Well, first of all, I'll remind people, if you would like to ask Shelly a question, we have about 10 minutes, please enter it in the Q&A. So you just click on the Q&A tab and you'll see a box where you can type in your question, and we'll do it that way. So the first question is from Chris, and he's talking about the studies that you referenced early on in the presentation, Shelly, and he is wondering just how it was measured, or was it self-reported? Do you have any ideas about that?
Yeah, so I assume how it was measured. I'm assuming the it is the self-compassion.
Self-compassion, yeah.
Yeah. So it was measured with it is self-reported. It's a questionnaire, and it's the self-compassion scale. So it's a questionnaire that Kristen Neff developed, and I think it came out around 2003. And it has been validated, and I talk a little bit about that in the book chapter. But they're still working on trying to refine it, let's just say, as far as reliability and validity. But yeah, it's the self-compassion scale, and you can find it if you go on her website, the resource. I'm still sharing my screen, right?
Yeah.
So if you look there at the bottom, Chris, a NEF, self-compassion.org, and if you navigate her website there, she actually has the self-compassion scale right on there. You can look at it, and she even says that you can use it, in your clinics, and researchers can use it. So, and that is the standard. That's what people are using across the research.
Brilliant. Okay, Callie has a question. So in your experience, what's the best way to encourage self-compassion in our clients? Is it just by showing it to them, like demonstrating it, I guess, loving kindness meditation versus a handout, or something else? What are your ideas?
Wow, Callie, thank you. Oh, that's great. I don't have an answer for that as far as, one way or even a handful of ways. But I'll speak to that, what's been working for me, or some different things that I've done. So I'm at a point in my career right now that I don't have this as something that's standard. So I don't take the self-compassion questionnaire and give it to everybody or anything like that. For me, it's something that's, as of now, a little more organic. And usually it's after spending some time with the person. It might be after the first session, but it's just where our conversations take us to. Maybe it's the language that I notice with the person, you know, that they're speaking in ways that makes me, you know, think, oh, maybe they're low on self-compassion. And then from there, I may suggest to them. So it maybe just be sort of like an educational, just a couple minutes, and just suggest to them, hey, you know, I've come across this work. And so I tell them a little bit about what I've learned and what some other people have been benefiting from, and about self-compassion. And then I basically ask them what they think about it, you know, to kind of get an idea of where they're at. And as you know, with many things, once you get an idea, if there's interest, or they may say, yeah, I think I do struggle with that, or, you know, it just depends sort of on what they're saying. And then from there, I would say, would you be interested in some resources? And I've done things like just given them the selfcompassion.org website, Kristen Neff's website, phenomenal website. There's so much on there, and so much of it is free. So I may just do that and then follow up, and then that fosters more discussion because they found it very fascinating, or they took the self-compassion scale, the test on their own. So it's a little bit more organic that way. And then, you know, as far as the actual how to help people cultivate self-compassion, I've tried lots of different things. So one, actually just recently, recent being a few months ago, I had recommended a self-compassion letter because that's one of the practices. Now, doing that, again, I didn't just sort of say it out of nowhere. Over time, we've been having these discussions, and I asked the person, well, what would you think about writing, you know, a love letter to yourself? And, you know, and so we talked about that, and they did that, and it was, you know, very profound for them. Another just little tip, Callie, is what I do is, so just kind of, you know, staying within my scope as a physio, often what I'll do is I'll just suggest these things, but I'm not expecting them to come back and report to me how the letter writing went, or if I suggested a loving kindness meditation, gave them a link. You know, they don't need to come back and show me how they did it, or these are just things for them to explore. So I hope that helps. I guess to recap, the self-compassion letter, yes, a loving kindness meditation, and even just using those three components of mindfulness, common humanity, and kindness. So what I've done with people is just say, hey, take a moment, if you can practice next time you're feeling this, and just acknowledge. And then the second part, see if you can self-talk a little bit and say, you know, I'm not alone, there's other people. And then the third part, extending kindness, I may help the person decide what that looks like for them. So it might be hands to heart saying, I'm enough, just silently. It might be, if they're in a situation, it might be just even caressing their thumb, just sort of a little self-soothing physical practice. Or like I said, it could be maybe they just need to remove themselves from this situation and just be silent and do a breath practice for themselves. So I hope that helps. A little bit long, but.
Shelly, that's really interesting. And so you're really talking about, I guess, you know, you're establishing some trust, and then you're raising the issue of self-compassion, and you're pointing them to either kind of practices they can do, or education, you know, some further education that they can then read about. And then you're also talking a little bit about like modeling the kind of self-compassion you want to see, behaving in kind ways, and just helping them sort of I think probably become more aware of it through your own behavior.
Right, and Callie did mention that, and I didn't speak to that, and I 100% agree. And just, yeah, you got it, just modeling it. It's quite and when you start to expose yourself to this in practice, you'll start to notice that a lot of it is quite organic. The modeling is so key. And then even your own language as the healthcare provider. You know, it as even how you're maybe not just, I don't want to say talking to the person, like at the person, but even just when the person maybe says something like, oh, I they're shoulding themselves. Oh, I should have been able to do that. And I can't believe it's, I can't even lift the boxes up on that shelf. Like and you hear the tone of voice. And then that's an opportunity to, to jump in and maybe a little bit of motivational interviewing too, and just suggesting, do you tend to be, I think I did that actually. I'm trying to think of an example to make it tangible. There was a case almost similar just to that. And I had asked the person the question, do you think you're a little hard on yourself? Like, do you have those tendencies? And of course the person said, oh yeah, 100%. So then there was an opening to further explore the self-compassion piece.
Okay, well, I just want to say thanks everybody for attending. It's 1 o'clock now, so we will wrap it up. Shelly, if someone has a question, can they contact you?
Yes, please do. There's all my links. My website, you can contact me straight through there. And that's probably the best way to contact me is through my website. Yeah, please do. Please do.
Brilliant.